CTSNet friends, welcome to another in the series of the CTSNet Beat podcast. My name's Joel Dunning, bringing you all that's good and great in cardiothoracic surgery, and we've got some absolutely fascinating articles for you this week. A really good Lancet publication all about the sequence of events in the demise of the first ever human pig transplant as a transplant recipient. Really fascinating. Not often you see a case report of a single case in a Lancet publication, but yeah, I'll tell you more about that. The second article is septal myectomy, but not through the aortic valve, through the mitral valve. And the third article is all about type A dissections in the under 30s. We've also got some amazing videos for you. We've got a high-grade osteosarcoma that goes into the heart, a heart and lung operation. We've got a really good ISMICS key address, and we've got a summary of everything that was wonderful in June. So stay tuned, keep listening to this CTSNet podcast. Article we've selected for you in Jan's is published in the Lancet. It's by Bartley Griffith, the professor who put in the world's first successful pig transplant into a patient, and Mohammed Mohideen, who is the brains behind it as well, who's also knows so much about the immunology. And they did a really fascinating article in the Lancet, basically documenting the three things they thought that caused the demise of this amazing, groundbreaking patient. So you might recall that the patient was a 57-year-old. He was called David Bennett, and he was there at the University of Maryland, and he was not eligible for a heart transplant. So very bravely indeed, he said that he would be happy to have the first pig genetically modified xenograft, and the US FDA granted permission under its compassionate use system. So they put in the pig's heart and actually did really, really well. His echoes were functioning brilliantly until day 47, got out of hospital, and then there were a series of events that led to his eventual heart failure and rejection. They described the fact that they thought there were some overlapping things, and three things they highlighted. The first one was that Mr. Bennett was really ill. Not surprising if you're not eligible for a heart transplant and very ill. You've got to pick the most ill people to do these things on. But because he had such a poor state of health, he did become quite immunocompromised just himself innately. And this limited the use of some of the anti-rejection regimes that they were planning on using and that they had been using in the preclinical studies. So he was more vulnerable perhaps to a bit of rejection. The second thing is because he got some infections and he was immunocompromised, they used some intravenous immunoglobulins to try, so antibodies basically trying to attack the bacteria, but they actually thought in retrospect this might have triggered an anti-pig immune response, and they showed some evidence of antibody targeting on the vascular endothelium of the pig's heart. So that was number two. And then number three, they have just created a test to look for porcine cytomegalovirus. And they did feel that this pig had latent virus in the transplant, and this may have contributed to the demise as well. And they're now going to test for pig cytomegalovirus. So they do have three things now that they might be able to use in the future to mitigate against this. But great article, really interesting. True rarity to have a N=1 case report in the Lancet, but truly groundbreaking, and congratulations to these incredible pioneers, Bartley Griffith and everybody else there. It really is difficult to be so cutting edge, and congratulations. We look forward to the next time you try that operation. Secondly, another really fascinating write-up, and this is in transmitral septal myectomy combined with mitral valve surgery. So if you've got a patient with HOCM, I'm sure you normally go through the aortic valve, but they looked through their database and they found between 2017 and 2020, 14 patients where they had mitral disease. So they addressed everything through the mitral. Now, I did know that you could go through the mitral as a bit of a bailout if you can't go far enough with your myectomy through the aortic valve. But using this as routine in someone having mitral valve surgery, really I thought was quite novel. So this is published in the Thoracic and Cardiovascular Surgeon. This is by Farhad Bakhtiari in the Helios Clinicum in Siegburg in Germany, and is a really fascinating insight, very beautifully demonstrating their technique, including a really nice, quite quick video as well, provided by that journal, free and open access. So congratulations to that brilliant journal. It's a German publication, and I really like to see open access with videos there. So they found 14 patients that were having mitral surgery, and quite a lot of them were in heart failure, quite a lot of them were in atrial fibrillation. Their technique that they described, they had a 140-minute bypass time, say 78-minute cross-clamp time, and their mortality was 0. So it's a really good results. But what did they do? Well, mostly they cut the anterior leaflet and pulled it down so that they could get good access to the septum. They then cut, so they're using a right anterior thoracotomy as well. So they're not using a stenotomy, which is really good. So avoiding that stenotomy. And then they seem to have really quite a good view to cut out the septum. They were aiming for between 10 and 15 millimeters in depth to cut away. And then after that, they put a patch on this cut in the mitral, and mostly in 11 of them they managed to repair the valve, and in only 3 they needed to do a replacement. From my point of view, I was always really worried about how thick to make the myectomy. The best technique I ever heard was actually making a hole in the right ventricle and putting your finger in there and then feeling with both sides to feel how thick you've made it or thin. So I'm never quite sure how to best do it when you're just trying to cut this myocardium without knowing how close you are to the other side. They did say they used TOE guidance, but of course you can't do that while you have the left atrium open. But I was very interested to see that they did get really good results. They preoperatively planned it. They planned their depth of resection. So obviously they're very experienced, really good, and congratulations to this brilliant German team at the Helios Clinicum. And the third article we've got for you is another really interesting article. It's an EJCTS article by Florian Schönhoff and Maximum Luhr. And they work at the Heart Center in the University of Cologne in Germany. And this was a look through their database. They have a really amazing database of 16 institutions, and they have a huge database of 7,900 patients having acute aortic dissection. And out of them, they looked at the very rare group of the under 30s age group. They found 139 patients having this, and I'm sure if you've seen someone under 30, it really is a very traumatic for the whole team. They're so young and so high mortality that everybody just wants to push out the boat to try their very hardest for these patients. So what did they find? Well, interesting. You'd think that all of them would have a connective tissue disorder, wouldn't you? But actually they only found a no-named connective tissue disorder in 36%. That's a third. The other high level that they found in this was arterial hypertension. They had a 5 times higher level of hypertension than in those that had a connective tissue disorder. So perhaps those were the 2 things that accounted for this aortic dissection in such a young age group. And also 10% had a family history as well. It does leave you wondering whether the rest maybe had an undiagnosed connective tissue disorder. We don't really know everything about all the connective tissues. We know about Marfan's and Loeys-Dietz, but I'm sure there's many more out there, all desperate to be recovered. So that's what I often think. And actually, this article also showed that there was a operative mortality of 8.6%, really very high for a under 30s age group, pretty reasonable for a dissection group. And if you look through the table documenting how ill these people were, there really were quite a high level of people tamponading, some of them having massage, some of them had strokes or distal ischemia or renal ischemia. So they really were very ill group, and therefore to get an 80% 10-year survival and to get only an 8% operative mortality, I think was a really impressive effort through these fantastic 16 centres. So check that out perhaps in the EJCTS in this month's edition. So those are our 3 articles that we've got, and I'll just hand you over to our CTSNet office to tell you what else is on offer on the CTS website this week.
Submissions are now open for CTSNet's annual Innovation Video Competition. The competition rewards surgeons at the cutting edge of cardiothoracic surgery with a $1,000 cash prize, a prominent feature on CTSNet, and an exclusive interview with the judges. Submit your videos showcasing creative solutions, novel surgical approaches, and technological advances in CT surgery by August 31st, 2023 for a chance to win. For more information, visit ctsnet.org/innovation video competition.
Welcome back, and thank you for that message. So we got 3 really interesting videos. The first one's something pretty tasty for thoracic and cardiac surgeons out there. This was a 22-year-old man. The poor guy had an amputation for a left distal femur, high-grade osteosarcoma, and then was found to have a right middle lobe mass, but extending into the left atrium. And there's an amazing echo of this frond of tumour just floating about, poking in and out of the mitral valve there. So phenomenal echo. This video is from Sami Syed, our wonderful paediatric senior editor here at CTSNet from the Westchester Medical Centre. And Ali Mashadi did the narration, and I'm sure a lot of work. So they did a stenotomy. They put the patient on bypass, just a bicaval cannulation. They didn't do SVC, IVC cannulation. Then they opened up the left atrium, and there they saw this big finger coming out of the middle lobe vein into the left atrium. So they then did a big, huge window into the right chest. They preserved very nicely the phrenic nerve, and then they used standard techniques to resect the middle lobe. But then they opened along the middle lobe vein, cutting towards the left atrium that they'd already opened up, and then opened it out like a book. And then they lifted the whole tumour out, including that long finger, and then closed everything up really nicely. Very interesting video, really fascinating. And the patient left hospital day 3. Fantastic job. So really well done. It was 4 centimeters long, this tumour. And I certainly encourage you to check that one out if you have just 15 minutes in your day to see something really unique. The second video is absolutely outstanding. It's from the 2023 ISMICS Society, and it's their 2 keynote addresses. So the president, Vino Tirone, introduced these outstanding speakers, the first Robert Higgins and Michael Madius as well. And I was fascinated. They were really brilliant talks. Robert Higgins really is an extremely accomplished cardiothoracic surgeon. He's now gone into very high-level management, managing huge numbers of beds and hospitals. And so he gave a very high-level talk about the importance of innovation in today's healthcare, basically with the argument that, you know, we really can't do without it, and really, really interesting. And so this video is about an hour long, certainly suitable to put on the TV in the afternoon maybe, or the evening when you get home with a nice glass of wine. Have a listen to these 2 amazing giants of our specialty. And thank you very much to ISMICS for allowing us to share these, and they're going to share a few more of their presentations from the wonderful ISMICS Society meeting that they had last month. The third CTSNet content we've got for you is a summary of everything that was wonderful in June. We think our listeners and readers really like nice quick summaries. So if you haven't been able to log on for a little while on CTSNet, just go straight to this, and this shows the 10 most popular articles of June, and dive straight in and maybe pick 2 or 3 that really fascinate you. I'll give you a quick whirlwind tour of what was brilliant in June. The first one, the most popular clicked video was a post-infarct VSD closure without a ventriculotomy. I I thought this was fascinating as well. Enrico Coscioni and Mario Torre sort of gave us a great view, basically sort of using some of their congenital heart surgery experience to manage to not do a ventriculotomy, but going through the left atrium and through the aortic valve. Fascinating video, check that out. The top Jan's click was the amazing UK mini mitral trial, the randomized trial of around 300 patients of mini thoracotomy, basically port access mitral or conventional stenotomy. I'm sure everybody was fascinated to see the port access mitral technique really put under the cosh and really tested out. Whichever side of that argument you're on, I'm sure you'll love to see that. That was our Jan's top article in January. Our very best sponsored video was by Tom Verbellen, and he did a really great How I Do It video of a double valve replacement. So if you're a resident or a junior or medical student or just interested in how we do aortic and mitral surgery, this has both, beautifully described by Tom Verbellen. Another most popular article was aortic root replacement, repair or replace. So that was really, really nice. It's a Jan's article, and it was from a really big database. And I'm not going to spoil what the conclusion was, but check that article out. That was one of our Jan's. The most popular instructional video was a really nice video of hints and tips and tricks for internal mammary artery harvest. I'm sure a lot of the residents and medical students and juniors had a really good time checking this out. It's only about 15 minutes long and was really popular, and I thought it did a really nice job of showing those techniques. And a really good one if you're low in experience taking the mammary down. Just check that out while you go. There are a few more really good videos. The most popular guideline was the ISHLT guidelines for mechanical circulatory support. Sami Said had a couple of top hitters, anomalous aortic origin, the right coronary artery, and a sutureless repair of TAPVC in a neonate. And then the final few, there was a really interesting rapid deployment valve of a rapid deployment valve over an aortic mechanical valve, where Andrea Aldo showed us how they practiced to rip out the leaflets of a misfunctioning mechanical valve, and then they went into a patient to do a sutureless valve deployment over a mechanical valve that they'd taken out the leaflets. I thought that was fascinating. And the final one was a Ravitch repair and mitral, which I thought was one for thoracic and cardiac surgeons wherever they are. So a good summary of everything that was great in June. I hope you find something interesting in that. I found, frankly, all of them interesting, but if you haven't got the time, pick a couple of them there. That's all our content for this week, but there's some upcoming events. CTSNet is very proud to be combining with the ASAIO webinar, where they're doing an ECPR, Team Building for Success. It's on July the 13th. You can look in the show notes below and click across and register for free. It's going to be a free webinar. Check it out. There's going to be some really stellar panelists. The moderators, Ashok Kumar, and we've got some brilliant people, Jeffrey Keenan from Duke, Brittany Zwischenberger from Duke as well, and Jason Smith from San Francisco. They're going to talk about technical pearls, infrastructure, how to build a team, and outcomes and optimization. So if you log in live, you'll be able to post some questions, or if you don't have time for that, then we will of course post the whole finished video here for you to watch at your leisure. And that's everything for this week. Just two more things to mention. Where is Diego? Diego, the world roving thoracic surgeon. He's been in Europe, and now he's gone back to where his heart really is, back in the Shanghai Pulmonary Hospital. They're running another 2-week course there for over 40 delegates, teaching them all about everything that's good in uniportal VATS and RATs. You should have a look at the program. It's absolutely fantastic. They've literally listed live sleeve surgery with 130 operations going on every day. They can literally pick 2 or 3 sleeve resections to do by uniportal VATS and RATs. I mean, what a course. So check that out and maybe go 1 year. I think they're doing 2 to 3 per year. And so check that out if you like on the Shanghai Pulmonary Centre's website. All new buildings, all new theatres with 4 patients in, truly crazy. And then I would like to give our honourable mention of the week to Tirone David. This name is just a household name in the whole world of cardiothoracic surgery, and everybody knows Professor Tirone David. Of course, his incredible dedication to valve-sparing root replacement is his greatest achievement, and he obviously eponymously has given his name to the David procedure. So other things I love about Tirone David is that I actually talked to one of his residents, and he was stunned by how fast Tirone David is. If you haven't seen him operate, not a lot of people realise how quick and efficient he is. And he was actually asked once, how is it that you are so quick and fast? And he said, I don't know how fast I am. It's just the clock seems to stand still when I operate. Very interesting. There was also a study in efficiency of operating, and these researchers were really interested in ergonomics in surgical operating, and they said that the average efficiency of purposeful movement in a surgeon is about 65%. What do you mean by that? Well, it's like when you go to do something but do something else, or you put your hand somewhere where you're not doing something purposeful. That counts as a non-purposeful event. So the average is 65 for a surgeon. Tirone David scores 95%. So I think there's something he can teach us there in always trying to optimize every single move we do. But the reason I'm giving him an honorable mention this week is he has generously given his week to come up to Middlesbrough to teach us aortic valve sparing root replacement. We'll be spending a week watching him doing his operations here in Middlesbrough. He's just come from the Brompton Aortic Root Symposium, and so he is so generous of his time. I just want to give a big shout out to him and a big thank you from all of us at James Cook University Hospital. So that's everything we have today on this CTSNet Beat. Thank you very much for watching to the end. Do please get in contact with me if you'd like to suggest any Jan's post a video, and otherwise I will give you a summary of everything that's wonderful and good in the world of cardiothoracic surgery next week. So do tune in then. Thank you very much.